Yes, I will make sure. So I will be joining you visually momentarily.
Awesome. Ah, there goes Dr. Friel.
Yeah, Friel, Charlie, please.
Friel. How are you, sir?
Good. How are you?
Good, good, good. Um, Very happy to see you.
Yeah, my pleasure. Thanks for
Yeah,
having me.
awesome. I see there's a lot of Massachusetts
I
history.
was thinking the same thing. There's a lot of I don't know if that's a good thing or bad thing.
This is like Kansas City Chiefs versus New England Patriots fight here, Go see.
Is Erica in the background there?
Yes, I am here.
Thank you for sending that last email. That was like crucial.
Yeah.
That guy was like, oh, now I gotta like search and find it. And how come we all have different links?
Oh, because you're panelists. So it's done via Zoom webinar versus Zoom meeting. So they're kind of two different platforms.
All right. Well, I appreciate the last email that made it like hopefully idiot proof.
You would be surprised the number of people that actually click on someone else's link.
Yeah.
Oh yeah.
And then when they join, like the wrong name is under them. So we know exactly whose link they clicked on, and we have to ask them to go out and, click on your real link.
Interesting.
Although maybe it'd be fun to have different names under our head, our faces. We could do like what is it, role modeling or
I see Jumi's online here. Hi, Jumi.
Hi, good morning.
Another UMass person here, right?
Yep. All the way.
All right. I think we're waiting for Dr. Tseng
And Thaker, right?
and yeah.
So everybody knows how to share screen. It's very, if you want, you could practice right now. If you plan to share your screen, if not,
No,
I have nothing to share. Is there something I'm supposed to be sharing?
no. I have nothing to share either. We're just having a casual conversation. So, Dr. Friel, did you get those questions that just kind of like general questions that I sent out?
I did.
Okay, awesome. And you also did get the paper from 2019 New England Journal of Medicine.
Yeah, the one from Carl Villamore. Yeah.
Yeah, awesome. How many residents do you have in your program?
In our program, currently we have 5 residents per year. But we just we're moving up to 6.
Oh wow.
So we have 5, and then we do 2 lab years. So all told, we're kind of hovering around, and then we have about somewhere between 5 and 8 preliminaries. So all told, it ends up being close to 40 people.
Wow. That's a lot.
It's always a lot of personalities.
Yeah, it's a lot.
Balancing.
I think that's one job I don't think I can do.
That's not there's a lot of the positives outweigh the negatives. I mean, the cool part is you just get to see young people. I mean, I'm still thinking I always joke with all of the applicants, if they can make me into a surgeon, we can make anybody into a surgeon. But it is amazing, right? You show up, you don't know anything, and you leave a surgeon. Like it is like a little bit spectacular what happens, and like I know it takes a while and feels like it's forever, but you're fundamentally changed. You're not a different person, but you're just changed, right? Like
yes,
and it takes 10,000 hours. I mean, or whatever.
It does.
But I always think like, all right, like if I just sat, if I had decided I was gonna be a guitar player and someone just put me in the guitar residency and I just played all nonstop for 5 straight years, that'd probably be pretty good, wouldn't
That
I?
is true. That is true. 100%. And I guess consistency and discipline, and those are the two important qualities to make it happen. And I think general strategy allows that. If you don't know what you're doing, I mean, those two qualities tend to be lacking, right? To result to that. So let's see, general strategy.
So do I say your name, Megafu?
Yeah, Megafu is my last name.
Oh, Megafu is your last name.
Yeah, Olajumoke is the first name, but everyone calls me Jumi.
Calls you what?
Jumi.
Jumi. And Jumi, are you from UMass?
Yeah, that's where I am right now for residency.
Cool. So you know my buddy Justin Mako and Kareem Alavi and
Ew, I
Yeah,
do.
yeah, I know both of those two.
You do.
Yeah.
and also Lindbergh's there, right? James Lindbergh.
Greg is here. Yep, Dr. Limber is here. Sir Jonk.
He was
Dr.
he did
David.
residency down here.
Yes, he did. Dr. David's just left for another position. I don't know if you knew her at all from UMass. She just left for BMC.
Oh yeah, Jennifer, yeah. I almost worked there.
Yeah.
Justin tried to get me to come up there. I don't know. That was 15, 16 years ago. It was just him and Kareem at that point. Oh, and I guess Brian Sweeney was there.
It's funny, I was doing a project and I was looking at the attending names from back then, and Dr. Sweeney kept popping. I was like, oh, he must have been a colorectal surgeon here years before I started.
Yeah. Brian was an old military guy that went, actually, he was at Minnesota when I trained at Minnesota.
Okay.
And then I think that's partly how he got connected with, it's all, I mean, Kareem, Justin, myself, Brian, we were all Minnesota people. That's how we kind of knew each other.
Nice.
And then Justin and I were residents together way back when.
Both of you go way back.
Oh, really?
Yeah, I was his
Oh.
chief. I was a 5, and he asked me, he'll tell I tortured him. Actually, his wife is still mad at me, apparently. Because you tortured poor Justin. You made him work all the time. Because it was Chris Foglia, who's also a colorectal surgeon. His license didn't come through or something like that. So he couldn't start as an intern. So poor Mako ended up having to kind of continue his internship.
Sure, that was fun.
I'm sure he'll remember.
I'll have to ask him next I see him. Like, Dr. Friel told me that he gave you a little torture time when he was your chief.
Yeah. He tortured me right back, believe me, if you can imagine.
Knowing Dr. Mako, he made sure he gave it back.
So, guys, we have a minute. Dr. Tseng is not on yet. Erica, you don't have a contact info, do you, by chance?
I just have her email. She was one of the people that did accept the invite. I could try to send her let me see if I have her cell phone number somewhere.
Let me see. I don't think I have it, but she was at UMass.
Yeah, sure.
Yeah, I got her email. I don't have her. Actually, when I interviewed there, she was there.
Is she first or second in the lineup, or
She's second.
second? I'll keep trying to reach her if you want to get it started.
Yeah, otherwise I'll ask Dr. File all the questions.
Oh man, this is gonna put I need like a chair perspective.
Yeah, I know. That's what we're waiting for here. But let's
Otherwise, like I'm gonna say all these things, and the chair is gonna come in and say we can't do any of that.
no, we'll keep it clean. All right, so I am going to be starting the webinar here in 2 seconds. Okay. Once we start, I'm going to give a little bit of introduction, and then we jump right in. Okay. Starting. Welcome to the Coffee and Conversation of Diversity, Equity, and Inclusion Committee of the American Society of Colorectal Surgeons. I am your host and moderator, Rob Amajoyi. I'm a colorectal surgeon here in Kansas City. Coffee and Conversation is an educational program designed to address physician and patient-centered experiences related to diversity, equity, inclusion, accessibility, and justice through casual but expert conversation between surgeons. These conversations are available for viewing to anyone with access to the Askers YouTube channel. This programming will be brought to you every quarter, so be sure to check out our previous episodes. Today's episode is on navigating surgical residency training as a woman. General surgery residency training is fundamentally long and demanding. The purpose of this session is to help offer guidance and strategies to empower aspiring female surgeons on their journey through training. Joining me to help shed light on some of these issues are two incredibly well accomplished expert surgeons, Dr. Friel. Dr. Friel is a colorectal surgeon, a professor of surgery and general surgery program director at the University of Virginia. He graduated from Harvard Medical School in 1993 and then completed his residency at Beth Israel Deaconess Medical Center before completing his colon and rectal surgery fellowship at the University of Virginia. Dr. Friel is an incredible DEI advocate. He currently serves in the Askers DEI committee with me. Welcome, Dr. Friel. Sorry.
No worries.
Yes, sorry.
Thank you for having me.
Dr. Tseng is a surgical oncologist, a professor and chair of surgery at Boston University and surgeon-in-chief at the Boston Medical Center. Dr. Tseng did her surgery residency at Massachusetts General Hospital, followed by surgical oncology fellowship at the University of Texas MD Anderson Cancer Center. Dr. Tseng began her faculty career at the University of Massachusetts Medical Center in 2005. She was then recruited to Beth Israel Deaconess Medical Center and Harvard Medical School as chief of surgical oncology in 2011, where she rose to the rank of professor of surgery at Harvard. She's immediate past president of the Society for Surgery of the Alimentary Tract. She's a founder and past president of the Society of Asian Academic Surgeons, and is a member of the executive councils of the Society of Surgical Oncology and the Society of University Surgeons. She's also the chair of the research committee for the American Board of Surgery, where she's also a member of the American Board of Surgery Council. Dr. Tseng is a deputy editor for JAMA Surgery and serves as a number of editorial boards. That's a lot. Welcome, Dr. Tseng. Joining us here with us is fifth-year resident Dr. Calli Schardein, who is applying for colorectal surgery fellowship this year. A fourth-year resident Dr. Garima Thaker, and a second-year resident Megafu from UMass. Both are interested in colorectal surgery as well. So welcome, everyone. So guys, here are some statistics. 20% of US practicing surgeons are women. Okay, 40% of the general surgery residents are female. So applications coming in is now showing it is closer to 50-50. So this is a big shift compared to decades in the past. So despite these strides we have made over the years, there are still issues that are happening. So one of the issues are autonomy in operating room, mistaken for nurse or other healthcare personnel, the double bind phenomenon, work without reward, microaggressions, mistreatments, etc. Are some of the historical challenges that are still facing women's surgery residents today. My take is that this is everyone's problem to solve, because some of us either have wives, sisters, head aunties, daughters that are currently or going through or have been through general surgery residency. So Dr. Friel, I'm going to start with you. You've been an incredible teacher to many. You have a very large and successful program down at University of Virginia. Your records obviously speak for itself, and we're going to need you to help us unpack this here in a minute. But, you know, there's an article most of us have read, the 2019 New England Journal of Medicine paper on discrimination, abuse, harassment, burnout in surgical residency training. That paper was actually derived really from the results of a survey appended to the 2018 American Board of Surgery in Training exam. That paper reported that an estimated 7,400 residents from all 262 residency programs across US took the survey with a striking 99% response rate. In that survey, however, what's more striking to me is 65% of women reported gender discrimination. So 2 questions for you, Dr. Friel. One is, what is your philosophy on all of these, and what advice would you give these young women and those listening out there? That's the number 1 question. Number 2 is, what are the ways these residents can optimize their surgical training?
Wasn't really prepared to lead off, because I think at the end of the day, I'm here to learn and listen as well. I think, you know, as a PD, as a program director, and a male program director, in coming from training in the 90s, when, you know, truthfully, there was a lot of women in my program, and in my fellowship, there was 4 of us and 3 were women, and my program director was a woman. It was Dr. Ann Lowry. So, like, I've been around really high achieving surgical mentors that have been women for years and years and years, but, you know, it wasn't necessarily true across the board. And you're right, the numbers have gone up quite a bit. So, you know, I think that in general, you know, the way I look at this is that, you know, we want to make everybody successful, right? And so whatever environment we create, it has to allow growth of the individual, right? And we need to make that happen. And we all come to the world with biases, and we all come to the world with kind of ways that we see the world. And so what we really, really need to do, especially if we get in, you know, PD positions or chair positions or whatnot, but also when you're running your team, is listen, right? And listen to everybody around you, and you know, try not to get so frustrated by all the stuff, and really try to kind of see the point of view from somebody else. Because every interaction and every kind of you know, developmental process, we bring ourselves to it, and we have to kind of be able to kind of see it from different perspectives. And so, you know, I'm going to try to step back a little bit, because I'd like to hear from our trainees and Dr. Tseng too, about that perspective as well.
So yeah, thank you for that, Dr. Friel. Dr. Tseng, you've had an illustrious career, unbelievable, incredible. And it's very nice to have you on this platform as a chairman as well. Same question as above. What advice would you give? What has worked for you? Because obviously the result speaks for itself.
I think it's different now, and it's great to have. I like Dr. Friel. I'd really rather hear from the residents than hear myself talk. I went through residency from 95 or training from 95 to 2005. So this is now the dark ages, I think. I mean, even when I was there, we knew that we were the weakest, most coddled residents in the history of residency. We were told that because we had moved from every other to a combination of every other and every third night call, that we were weak. We knew that. We knew that the previous generations had worked really hard and walked uphill back. So please do not listen. This is parenthetically, and this is everybody of any gender. Please do not listen to anybody who tries to tell you that the residents today are weak and you have it easy, and that in the old days, you know, in my day, that's all hooey. So don't listen to anybody. You guys, you all are as strong as anybody else, and you are as good residents or better residents than we ever were in my version of the Dark Ages. And I submit that Dr. Friel and I were as good or better residents than they were in the days of Schwartz and Savastin and DeBakey at all. So there's no reason for any of you to feel inferior or insecure or weaker than your predecessors. And so just take that, and with that comes, I think, the completely needed, welcome, and great diversity that we have some of and need more of in surgery today. And by that I include gender, I include everything. We just had our access meeting at Boston Medical Center yesterday, our second access meeting, which is our new, I don't remember the acronyms, but it's our new DEI plus committee that comprises residents and fellows and students and faculty, along with diversity along all aspects. Because here in our program, we are 60 to 67% female. We are 30 to 40%, depending on the year, underrepresented in medicine. We are 25% LGBTQ high A in my program. And yet we still have issues to work on. So for me, and again, this is the Dark Ages, for me, I think being a resident first was how I survived. Was I came to my residency, which at the time was an extremely majority empower residency, and just put my head down and swore that I was going to work as hard as I could and just survive. And so I think those of us in the past did that more. I think, I did that without even trying to bring parts of our essential selves into our training. We were just surviving. I think we were hiding. We were hiding essential parts of ourselves as best as we could, whether it was, you couldn't hide your gender per se, but you could try to make it not an issue, as it were. People definitely tried to code switch. And I'm speaking more of things other than gender is one, but also especially in terms of race. And I think now we're stronger because people don't have to hide as much those parts of themselves. But I would say for you all now, I think knowing that self-confidence, that you're chosen for a reason, and that we choose people for a reason, that you are a great surgical resident, and then figuring out how much of the parts of your identity, including being a woman in this particular case that we're talking about, into what bears into being a surgical resident, I think is that magic. There's no magic formula. It's different for everybody. That was a long way, perhaps, of not exactly answering your question. I could detail. I'm shocked that the answer in the first trial wasn't 100% experienced harassment or discrimination. I'm shocked. I think people are underreporting, and you could argue, and many have, like, what are you reporting? Because is it worth reporting every time somebody thought I was a nurse? I mean, it happened to me like the day before yesterday. So I'm not kidding. And is that a microaggression? Sure. For me at this age, it's funny, and with my position in my hospital, it's funny. But when you're a resident, though,
Yeah.
it can be soul stopping. It can be heart stopping. And you work so hard, and you see, and because this happened to me too, and it happens every single day. You work so hard, you're dressed identically to your peers. You are treated differently than your peers that differ from you only in terms of, in this case, we're talking about gender. So two people walk into the PACU. One is a female of any race wearing scrubs, and another is a male wearing scrubs of any race. Let's just say white. And so then he walks into the scrub, and then is the nurse going to more likely think that the woman is a surgeon, a surgical resident, or I mean, it just. Even is another doctor more likely to think that the person is X, Y, or Z? That happens every day, day in and day out, to every female resident that exists in surgery. And so you have to decide on some level, on an individual level, how you're going to deal with it. yes, we need to change things overall, which is why things like this are important, by saying, educating people like me, educating people like you, to even assume. I have made assumptions in my life as a Asian woman. I have made assumptions that somebody was probably a nurse when they weren't a nurse. So we have to educate, but also from the individual, you have to, as best you can, not let it kill your soul. So, and to learn to combat it. So I will say that I'm wearing a white coat. I don't always wear a white coat, but in my white coat, I have cards. I learned, like I saw a consult. I was in the OR on Tuesday, and I went to go see a new consult for a new pancreas mass during the case. I actually have cards that I carry with me, so that if I go see this consult in between a break in the OR, and I meet this new patient, I say, I'm Dr. Tseng, I'm the surgeon, I was called to see you. I leave my card at the table. And so that afterwards, the patient is much less likely to say to their family when they show up, oh, I'm still waiting for the doctor to come by. Some nurse came by and said that something about surgery, but if I leave a card, that at least they have something that has my name. If I don't have a card, I'll write my name down. And then I try to wear a white coat. I try to dress quote unquote professionally. And we could argue about professionalism and who looks professional, and that's also another implicit bias. But I try, as far as it's not, again, mind numbing, to, as best as I can, do what isn't painful to me, to appear more professional, even though people shouldn't judge me more than they judge somebody else who's of a different gender based on how I look. So I think externally we need to work to change the externals and the biases, but internally each woman needs to figure out how to present herself in a way that doesn't kill her, to be taken as professionally and as a surgeon as much as she can.
Wow. Thank you so much, Doctor. I will come back to you. That's unbelievable explanations there and insights. So switch gears. Let's bring in the residents. Dr. Schardein, I'll start with you. You're a fifth year surgical resident. What would you say has been the most challenging thing for you to overcome? That's the first question. And then the second question is, what are some of the differences in training women experience? What are some of the values women bring to the surgical field to improve diversity and inclusivity of care? Go ahead with that.
Thanks, Dr. Amajoyi, and thank you for having me. And Dr. Friel and Dr. Tseng, specifically, that was pretty profound. So I appreciate you both being here. It's always helpful to kind of hear those that have come before us. I think coming into my fifth year, I've realized that some of the biggest challenges for me specifically as a woman in surgery stem internally, more of an internal locus of challenge. I think growing up, especially high achieving women, we have this drive to be everything, to be caregivers and also intelligent and, but gentle and strong and feminine and masculine. And so we bring a lot of needs to the table to demonstrate that we are capable of filling all of these roles. The combination of all of those roles is oftentimes impossible and not true to who we are as a person. And so I think for me, the biggest challenge was overcoming myself and realizing that being who I was brought the most value to my surgical education and to my patients. And if that meant that I wasn't the stereotypical surgical resident, then that was okay, because the stereotypical surgical resident may not have handled a situation as well as I would have handled it that day. And I think that that was the biggest challenge for me specifically. And then watching junior residents and female residents come behind me who would, we went to a journal club last night and one of the interns said, to wear makeup or not to wear makeup. And there was a lot of debate. There was more debate than you would think there would be. And we had a more senior resident said, the problem is if you start now, it will be heartbreaking if you ever stop, because every single person that day is going to ask you if you feel okay. They're going to ask you if anything is wrong or if you're sick. And the only thing that's going to have changed is that you didn't wear makeup that day. And it's a very personal choice. And it's such a silly thing to think that there would be so much thought into it. But this is something that this intern had belabored over. And so I think another challenge is knowing that this has been going on for years. This has been going on since women have joined the surgical specialties, but that we still have questions about whether or not wearing makeup to work is an appropriate thing to do. And so watching them go through the same emotional turmoils that we all have experienced, and knowing that they're going to overcome it, but it's going to be a process and a journey. I think that what women bring to the table is invaluable in the surgical specialties. I think especially in colorectal surgery and surgical oncology, these are an extremely vulnerable patient population. And I think that what women have to offer is something that can't really be expressed in words. I think for me specifically, I like to be the first person to make contact with a patient, especially if there's bad news to be delivered, because I think we do a lot of talking, but we're profoundly good listeners. And so I like to be one of the first points of contacts for delivering bad news, because I know that one of my strengths is being a good listener. And I think that patients do well with people who look like them. And so we have female patients, we have diverse patients. And so more so than as a white female resident, the intersectionality of female empowerment in surgical residency is even more important, because those patients need to see doctors that look like them. So I think those are some of our next challenges to overcome. And I think that things like this podcast, are so important, because we have residents behind me that can reach an even bigger group of people and patient populations. Excuse me.
I'm so proud of you. That's unbelievable insights and quite a nice vantage point. As a male, surgeon, and having gone through residency, I never even thought about makeup. I mean, what is that? So let me bring in
this gets a little bit at what Dr. Tseng was kind of alluding to, is that especially in the past, like, people would try to hide, right? So like, they would try not to do stuff, like they wanted to minimize that stuff. And I think the fact that you're having that, like, we shouldn't be hiding, right? You are who you are. What I love to tell my applicants is I don't even want to change you as a person. What I do want to do is convert you to be a surgeon, right? So, at the end of the day, that's what you're there residency for, right? You are training to be a surgeon, and we never can lose sight of that. That is our goal. We are not trying to change you fundamentally as a person. Like, we want you to be the person that you are, and I think that's going to strengthen the field.
right.
And becoming a surgeon does not mean you become a different person.
That is true. Let me bring in Dr. Thaker. She's a third-year surgical resident at the University of Missouri, Kansas City as well. Are there some common stereotypes you hear, or any discriminations that you have faced as a female surgical resident?
Yep. Hello, I'm Garima. Thank you for having me here today. Everyone's kind of mentioned this a little bit, but I think the big thing we get mistaken for are nurses. Like Dr. Singh mentioned, walking into a room with your male counterpart, they're more likely to be dressed as the doctor or the surgeon in charge. I definitely think that it's not maybe as prevalent now as it had been previously. And I think we're thankful for the women and the people that came before us to help pave our pathway. Even in our residency, I look at my juniors and seniors. I look at my female staff, and I think a lot of the growth comes from finding your voice. And like we've mentioned, not hiding who you are. It's okay to wear heels if you want. It's okay, like we mentioned, to wear makeup if you want. Like, we don't have to hide behind who we are necessarily in order to go through this training. And I think that's something that I've come to grow and learn with, from being an intern to now just a new fourth year. And I think that is a really important thing, that when I look at my interns, I look at my juniors, I want them to realize that it's okay to be different, that not everyone's going to look the same. I remember really vividly one of my chiefs last year was really good at showcasing that it's okay to be feminine. It's okay to, wear heels sometimes. It's okay to go down to the trauma bay in your heels. That doesn't make you any less of a surgeon. That doesn't make you any less of a person. And I think those are the big important things, that even if there are common gender stereotypes or discriminations, just coming back to how you can help the future generation in front of you or behind you by kind of combating those in your own ways and working through your internal struggle, which I think is, like we've mentioned, the hardest part usually, is just not hiding who you are.
So do you think you're surrounded by pretty strong female role models?
Yes, definitely. I feel very lucky to train at a program where we are led by a strong and fearless program director who always vouches for us, no matter what it is. I feel lucky to be surrounded by a female staff surgeon, chief residents above me like Dr. Schardein, who are very powerful and kind and caring and kind of are good, excellent role models for the people that come below them, whether that's in the operating room or outside the operating room. I think those are inspiring to see. It's inspiring to see female surgeons juggle multiple roles, like being a mom and a wife, and all the while making it look so easy. I think we're very, very lucky to be training in a program as such, where we're surrounded by that.
Awesome. Dr. Megafu, let's get you in here. You were second year. I think you in your research here as well. What's your experience been at UMass?
Yeah, I'm currently in my second year of research now, so it's been a great time. I think in general, coming into residency and wanting to do surgery, I think there were always like these conceptions out there of what surgery was or is, and whether or not you're sure you want to do that. Is that, are you sure you're going to have time? I remember having friends and family, not necessarily in medicine, but having seen surgery from the outside looking in. Are you sure like that's something you want to do? And I can say for a fact, one, I'm very happy being a surgical resident, but also particularly at UMass, it's better than I thought surgical training could be. Particularly here, it feels like a family, all the way from our chair to our PD to our co-residents, even down to our med students that we work with. It's been an environment where a concept can be brought in and grow and develop, and you'll have support from all sides. So it's been great. You get integrated into the OR early here. There are open conversations, and like Dr. Tseng had alluded to earlier, there's a lot of advancements that have been made, but there is also acknowledgement that there's still room for growth, right? And I think that the fact that programs like UMass that can recognize that we have made a lot of advances, but there's still a lot of room to move forward, because what is the goal, right? There's always room for improvement. And I think having that acknowledgement is great. And being a woman here, I remember being in situations, largely a lot of the colleagues and staff that I work with, I don't feel any different in terms of being a surgeon here, a training surgeon. It's more so probably from the patients. And I can vividly remember some of my attendings who are males, or even nurses that are in the room, and they would be looking to them while I'm in the room, having introduced myself as a surgical resident, saying this is the plan for the day. And they'd be looking at the nurse or my male attending who hasn't spoken in the room, and they would refer to me, like she will give you the plan. And I love that, because I think more than anything, as we need to internalize and, be okay with ourselves, we also need advocates who are not in those spaces to advocate for us in situations where it may not be easy for us to either stand up for ourselves, or it may be, but sometimes you just need that extra voice to affirm our position. So I'm very grateful to be working in a space here like UMass.
Good. Thank you for that. And I think there's one more question I had for you. I think it's about how you manage some of those disparate treatments you get, being in the operating room or in the wards.
Yeah, I think thankfully, like as I said earlier, a lot of the disparities that I do encounter tend to be mostly from the patients and not from the direct workforce that I'm with, which is great, but also something that, as Dr. Tseng has said, as Dr. Friel has said, no matter where we are in life, no matter, how high up in our position is as women in surgery will probably always be seen a little differently from our patients. And I think that in those situations, it's important to remember that, one, I deserve to be here. I'm here for a reason and a purpose. And that even in these situations, Michelle Obama always said, you know, they go low, but we go high, right? And I think I always tend to give myself a little pep talk in certain situations like that, conduct myself with poise and grace, because the worst thing you can do, especially for me as a Black female, is to all of a sudden come out with rage or be annoyed or be pissed off, because even though that would be a normal response, you know, it would be attributed to certain of your identities that it shouldn't necessarily be. So do we have to step up a little higher and you know, conduct ourselves with a little bit of a higher standard? Yes. And I think that in those situations, that's what I tend to do. And sometimes, you know, I do, you know, in talking to co-residents or people from other programs, surgery and not surgery, your mental health comes first. And if in certain situations you feel like it's just too much for me, you just walk out. There's no need to, you know, feel like you have to fight every battle. I think you choose the battles that come, and at the end, hopefully you win the war as becoming, you know, hopefully a well-established surgeon down the line. But I think mental health comes first, and putting that first, and in those situations where you can't stand up for yourself, holding yourself to a high standard would be very important.
Dr. Tseng, thank you again for Megafu. Dr. Tseng, let me bring you back in. For the issue on graduated autonomy in the operating room, as we know, as the residents progress through their residencies, there should be an associated increase in the amount of autonomy. But a 2017 multi-center study of the degree of autonomy that faculty gave thoracic surgery trainees, they found a significant bias against female residents. How did you overcome this issue as a resident, and what advice would you have given your younger trainee self to these residents that are listening right now, and what would they benefit from?
I will be honest, I don't think I overcame it as a resident. I think I suffered from lack of sort of self-esteem. I knew that I could work really hard. I was never sure that I was the best resident in terms of knowledge or clinical care. And I probably wasn't, honestly, but I was fine, but I wasn't sure I was fine. And then, so I don't think and like I said, I don't think I personally ever overcame it, except for the fact that I think I had mentors that actually would yell at me if I was behind, honestly, and would work with me on things, and then sort of believed in me and gave me chances and things like that. I think I think for younger people, if I could tell something to myself, or I could tell people now, I would say, I would go back to, you know, I'm so glad you're from UMass, but I'm glad to what you just said. You need to believe in yourself. You need to, because it's the same reason why some of the reason why women don't negotiate as much for salaries, that, like, we know, is because women are conditioned to be not afraid, but to not ask for more than maybe they think they deserve, or even what they do deserve. And men are societally conditioned to ask for more than they certainly deserve, and even more than they think they deserve. This is a trained societal, I don't think it's biologic, I think it's a trained societal thing that we do. And so we know how it works in the OR. So unless faculty are conscious to be like, okay, so this resident needs to be pushed. I need to make this, and I do this. This resident needs to be left alone to be. I mean, not left alone, like you're in the OR, but you're like saying, okay, all right, resident, let's see what you can do. Let's go. There's nothing you can do that I can't fix. And it's very hard in this day and age, right? But you need to get everyone. I'm lucky. I usually operate with chiefs on my big cases. I like to get every chief to a place, you know, to where they sweat a little bit, like that. And it's different for every person, but you need to be able to get them there so they sweat a little bit, like they're making decisions. Everybody's gifted in different ways. Everybody is gifted in different ways, and they have to learn to sweat. The person who's a clinical monkey, fine, they can sew and tie faster than anybody. I don't care. You need to be able. What's your decision making process? What's the next step that should happen in this operation? Not what you read or what you practiced before. So everybody needs to sweat. and you need to think consciously. Whereas I have had a third-year medical student, not here, thank God. I mean, I won't say thank God, but at a different medical school, a third-year medical student, a white male, who asked me to throw a stitch in the bile duct anastomosis as I was taking some female chief resident through the case. And I looked at him and I said no. But there was no way. But as a woman, I felt kind of bad for saying no to him. And the chief resident felt kind of bad for depriving this medical student of a stitch in the bile duct anastomosis of a Whipple. And I guarantee you, he didn't feel bad at all asking to do part of a case that was like way above him. So I think we need to make. Go ahead.
No, I was just chuckling. Finish your thought. Yes.
My thought is that I think it's multifactorial. As a resident, because I'm talking to residents now, as a resident, I would say, believe in yourself, practice, 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 which I would say to any resident, practice, practice, practice. When you're not operating, think, or when you're not holding, I guess I said, when you're not holding the stitch, practice in your mind. Think about doing the stitch. Don't think, I wish I were doing the stitch. I wish I were doing the stitch. Think, put yourself in, make yourself the best assistant and think about how you would do it. Be ready. Be ready for when that attending says, okay, you're going to do this bile duct anastomosis. Don't be like, well, I've never seen this before. Am I ready? And don't even say it to yourself. Just say, yes, I am ready. And then ask, come in the OR. Like if you're a 4 and you come in the OR and I'm doing a Whipple with the chief, I will ask the chief, is it okay if she does part of this bile duct anastomosis? You take her through it. I'll take you through the first half. You take her through the second half. Come into the OR. Pay attention. Think about what's going on in the OR, even if you're not being asked to tie or cut or sew at the time. And then be ready when you're tapped. Be ready and have confidence in yourself or fake confidence in yourself. Do the best you can. Have thought about it in your head a million times. And when it's time to do it, give it your best shot, knowing that your attending is not going to allow you to do something that's unsafe. You're good enough.
I'd like to echo that. Thank you for that insight. Obviously, I think I finished residency in 2011, and Dr. Friel, Dr. Tseng, you guys will agree with me that there's no better time to be a resident than now. You have 10,000 surgeons on YouTube showing their videos of whatever you want to learn. And this is the information age, and you can basically
watch Zollinger and Zollinger.
Yeah, exactly. Back then it was potentially outdated Zollinger version that you're looking at. So there's no better time, and I think if the resident prepares himself, I always say, my mentors always tell me that if you're excellent, then all of a sudden your gender, your race, whatever is overlooked, because you're just an excellent mind, and that's all there is to this. So that's my advice there. For closing comments, last words, I'm going to give it to Dr. Friel to give us his last statements, and because we got a couple minutes here left.
I'm smiling listening to Dr. Tseng, because I feel like I promise we did not like talk about this together, but like this is what I say to people all the time. And I think some of these feelings that you guys are talking about, we're talking about statistics here, right? Like, so, we all have a little bit of female in us, and we all have a little male in us, and we all have personalities and things like that. But a lot of these feelings that she was describing, I had, right? Like, I had a counterpart who was a male resident that took a trach, a percutaneous trach, and drove it through the esophagus and just ripped it to shreds, and then went home and didn't even think about it, right? And like, I was not my personality. I was always like, I did like, that would have scared, I would just doing it scared me. I was a little unsure. I had a lot of the same feelings that Dr. Tseng, and truthfully, it was disconcerting at times, because there were times where I thought, maybe I made the wrong choice. And a couple of things that people said to me was, I saw my evaluations, he's better than he thinks he is. And I think you have to constantly say that to yourself. Like, I 100% sure that every single one of us here are better than we think we are, right? We're our harshest critics. And you just have to keep plowing ahead. It does take a long time. There's a reason surgery residence 5 years, right? But what I loved about what Dr. Tseng said was, and I tell residents as well, like, if you want to do more, be willing to do less, right? And so what do I mean by that? So if I kind of take the case over, it's because I'm anxious about something. So yes, there's things that something you can do in theory that I can't fix, but there are things that you can screw up that are a lot harder to fix. Yeah. And so if I'm starting to kind of take over, it's because my anxiety level's going up. And so what you have to do as residents, not just as any resident, is help manage that. And then you should double down. You should focus. You should suck better. You should help. How do I assist? How do I move? What's the next move going to be? How do I get out of this? And then I will notice that. I will notice that you are engaging. And then when the moment comes to give it back, I'm going to give it back to you. And we're going to work because it's a team sport, right? But if you kind of roll your head and start to do this and go like this, and like, oh my God, they took it away from me again, it's never coming back, right? So you have to kind of see this as a team. And, and I love the idea too, that just go to the OR. Like, I do have residents that say that to me. Like, well, I go to every case I'm assigned. Well, go to the cases you're not assigned to, right? Because at some point it is awkward. If you're sitting in the corner and I don't let you operate, like, it gets awkward. So I say, hey, why don't you just scrub in? And that's a good thing. That's a good thing. And Dr. Tseng's exactly right. I'll say, hey, we're making the ileostomy. Like, I just assume, go get something to drink. Like, the chief, let the chief and the intern do it together. I'm not going to let them you do things that I don't think you could do. And then I'm going to make sure I come by and check. So, but that's how you're going to get engaged, and you're going to make your own autonomy, right? You can make your own autonomy. And the other thing is not to get too stressed out about it. I got very little autonomy as a resident. My residents get way more, but like, we had attendings all in the room all the time. And I was like super stressed about starting my practice. I was like, I've never been in the OR alone, like never. Like, Jeff Matthews left me in the OR for like 10 minutes and I, almost had a cow. But the day I went to the operating room as an attending, I just realized I was trained. Like I just fell back on all the principles. I could hear the voices in my head. And like, I was like, oh my God, I actually know how to do this. And then that couple first years of practice, you just build on it. So, make your own autonomy. You can do it. It's fun to get better at something. And, I'm still better than I was 2 years ago. And the robotic and it all changes. So you got to get better and better and better. It doesn't stop. I'm getting all excited.
Can I tell a funny anecdote at some point?
Yeah, go ahead.
Is that all right? Just, this is a real anecdote. I'm a resident. There is a really great chief resident at Mass General Hospital. There was, named Ray Lee. I'm giving his name because he's now a famous cardiac surgeon in private practice. He was one of the most technically gifted residents ever. Ray Lee, great guy. Anyway, he was well known as the greatest guy in the world. And so a resident shows up, and this is a little bit of microaggressions. A resident shows up, another Asian male resident shows up with a mask, assigned to a case, and the attending there thought he was Ray Lee and said, all right, Ray, get started. The resident, I'll call him future plastic resident. The resident, suck at your resident, okay? And he starts doing this big case. I don't know what it was, some big case. And they're like, Ray, what the heck? You should be good at this. Come on, Ray. And they kept riding this resident, future plastic resident, over and over again. Ray, come on. And the guy kept going. He didn't tell me he wasn't Ray. He didn't say, that's a microaggression. I'm another Asian male resident. He kept going. He just kept sewing, and he did the whole case, skin to skin, but while being berated as Ray Lee for the entire case. And it was only at the end of the case, when the attending was dictating the case, that the attending figured out that it wasn't Ray Lee, that it was future plastic resident. So anyway, to me, that kind of encompasses that if you can let the aggression, if it's not super offensive and if it's not soul sucking and if it doesn't, like, let that go for now and figure out how to turn it to your advantage if you can. And if not, insert yourself. You're good enough. You got to assume that even if the attending thought it was Ray Lee, was going to stop him if he wasn't really actually doing anything that was good for the patient. So take those advantages. Don't do that exactly. That was a different era, but you are good enough. Run with what you can. And women in surgery are, you guys are the future. You all are the future. You're better surgeons. The data shows overall that women surgeons have better outcomes, spend more time with patients. And some of this is societal. Do I really think that women necessarily are more technically gifted from like in utero? But whatever it is that makes society, right now, the data shows that patients have better outcomes with female surgeons. We know that diverse teams make better outcomes for all. So it is great for us to have surgeons that are of different genders and are from all different groups. That gives us the best outcome. So you all deserve to be here individually and as a group.
And I think that, we are talking about strategies about how do you as an individual navigate this stuff, because you do have to navigate it as an individual. I think then we have to periodically step back and as a group decide how do we make it better for the whole environment. So it's not that we're saying ignore these things. We're just saying that particular, like, you have a job. That's the way I always tell people. You have a job. Your basic job, your job is to get trained as a surgeon. That is your job. And all the other stuff is important, but that's not why you're there, right? And so every once in a while you have to remember that. But then we do have to step back, and this is where you challenge us. You come to us and say, hey, when we're recruiting, when we're doing this is what we need to do. This is how we're going to grow. This is how we're going to make the environment better. There's a lot of things that we can work on, but periodically you have to get a little selfish and say, fundamentally, this is what I want to be. And I will have a tremendous impact, not only on my patients, but on the surgical world for an entire career. So you do have to kind of decide what hat you have on at any particular moment and what your goal is at that moment. And that's not, and I don't have to do that. I mean, that is the advantage that I have, right? I don't have to do that. It's not fair. It's not necessarily right. It's just a reality though.
Right. So thank you so much, guys. I am going to wrap this up as we are approaching the last minute here. This has been a very interesting talk and conversation. And my take there is that, everyone needs a sponsor, an advocate, mentor, and a coach. They all mean different things. For instance, a mentor is just there and available for you and when you have questions and when you need them. And sometimes mentors can be mostly passive, but they usually make themselves available. A sponsor, on the other hand, goes beyond the social, emotional, and personal development traditionally provided by mentors. A sponsor, for instance, highlights the skills of their proteges. They actively look for opportunities that advance and elevate their proteges. A sponsor promotes, protects, and prepare and push their proteges compared to a mentor. I'm sorry, a sponsor does those things compared to a mentor. So it's important to know that an advocate, a sponsor, a mentor, and a coach are all different things. And rarely will you find someone that can be all four domains. And they don't have to be at or come from your institution. Some of my advocates and sponsors I've ever met, I've never really met them physically. So when you find that person, tell that person exactly what you want them to be for you. I say to the person, hey, I want you to be my sponsor, and define and spell out what to expect from them and what you plan to reciprocate in that relationship. So, I will say for the female residents, attend all the women conferences, like Women in Surgery conferences. That is how you meet these people. And remember, a sponsor, an advocate, mentor, and coach are all different things. And find who you want to be what. All right. So we can be going all day here, but thanks, Dr. Friel, thanks, Dr. Tseng, Dr. Schardein, Thaker, and Megafu for your time. I've learned a lot, and I hope our audience did as well. A huge thanks to the production team for putting this webinar together. As I mentioned earlier, the Coffee and Conversation programming is brought to you quarterly. So be on the lookout for the next episode. I am your host, Robert Amajoyi. Until next time.
Nice to meet you all.
Bye.
Thanks for having us.
Nice to meet you all. Thank you.
Thank you.
Thank you.